PhD. He's a consultant urologist with main interest in male infertility and laparoscopic surgery. He will talk to us about the male infertility for the next few minutes. Dr. Marhoon, welcome.
Assalamu alaikum warahmatullah. So I'll be basically talking about the male infertility, the current situation in Oman, in the Sultan Qابوس University, and what is our, planning for future and hopes. So I'll take you through the aim of this talk, and then what is the infertility in Oman current situation, what are the facilities available in, I was trying to use the laser, but it seems that I'm missing it. So then we'll talk about what are the facilities available in Sultan Qابوس University Hospital, and then collaborations that we are hoping to have, and then the project that we are thinking of, that is Sultan Qابوس University Fertility Center. So the aim is to establish a collaborative fertility center between Sultan Qابوس University and international centers. The situation in Oman, Dr. Maha has touched some of the statistics already, so I'm not going to repeat, and the information in this area is also scarce, so there are no accurate estimates of infertility in Oman that are known, and publications are very limited. From what I have seen, and Dr. Maha also had touched on that, in 2012, from the Minister of Health, that there are 5,537 visits for infertility issues to the health centers, and 4,000 visits for infertility issues to the hospitals. Little bit about history of infertility in Oman. In 1984, a small infertility clinic at Khawla Hospital started, and in 1981, male infertility clinic at Al-Nahda Hospital started. In 1987, there was a combined infertility clinic at Royal Hospital, and in 1996, the intrauterine insemination services in the Ministry of Health started. In 1999, female infertility clinic at Watiya Extended Health Center and male infertility clinic at Al-Nahda Hospital services were provided. As a combined infertility clinic at Sultan Qابوس University Hospital in 2000, it was started. And in 2014, very recent, we have started the microsurgery operations for male infertility. So there are 5 centers providing assisted reproductive techniques as a private centers in Oman, including Al-Bushra Medical Specialty Complex, Advanced Fertility and Genetics Center, Muscat Private Hospital, Al-Hakim Fertility Mother and Child Care Center, and New Life Fertility Center. Now, what are the facilities we are having at Sultan Qابوس University? As I said, recently we have started the microsurgery for male infertility, and we are doing microvaricocectomy, and we will soon start, in fact, next week, I'm having a case for micro-testicular sperm extraction, and we are going to provide the sperm retrieval techniques, vasovasostomy, and vasoepididymostomy. Of course, we do not have the assisted reproductive techniques in our hospital or any other government hospital, so I'm depending as a collaborative joint work with one of the private centers when it comes to the IVF-XC issue and the sperm processing and preparing it for the assisted reproductive techniques. Now, what are the facilities available at Sultan Qaboos University for andrology and for male infertility? The basic semen analysis is provided by our labs, and the advanced semen tests that we are doing include semen culture, post-orgasm urine for sperms, and anti-sperm antibodies. The basic supportive tests, including complete blood count, biochemistry, urine culture, and hormones like follicular stimulating hormone, luteinizing hormone, testosterone, and prolactin, they are all available to us. For advanced tests, sexually transmitted diseases, when needed, we can do HIV and hepatitis screen and syphilis, and more further studies as indicated for the patient, including the ACTH, thyroid function, growth hormone, and inhibin B. Agglutination tests are also available, and genetic studies, only karyotyping is available, but we do not have the X chromosome microdeletions. They are not available to us. The imaging techniques available to us, ultrasound, I'm talking here about male infertility, basically. Ultrasound testes to rule out tumors, transrectal ultrasound to rule out an ejaculatory duct obstruction, and MRI, the magnetic resonance imaging, when indicated for pituitary tumors. Now, having said what is the current situation, now let's talk about our ambition and dreams. With the wisdom of His Majesty, Sultan Qaboos, and with the support of the President of the University, and hopefully with collaboration with other centers, we are starting to put our feet and dream for what we want. We want a fertility center here to be at Sultan Qaboos University, to serve our patients and also to progress our research and academia. The center, which will be abbreviated as SQUFC, Sultan Qaboos University Fertility Center, will need urology facilities and gynecological facilities and collaborations. For the urology facilities, of course, we are having male infertility clinics, but we are aiming to have a more dedicated, more organized male infertility clinic. The microsurgery we have already started, as I told you, and we are going to build on that. We need a dedicated andrology lab, including all the facilities for basic and advanced semen tests, including cryopreservation and sperm banking. And we are hoping to have a stem cell research lab to go side by side with surface and research. For the gynecology facilities, of course, we need more dedicated female infertility clinics and IVF XC lab, that is in vitro fertilization and intracytoplasmic sperm injection assisted reproductive labs. Collaboration will be one of our aims, and we are hoping to collaborate with international centers, as an example, Royal Institute in Iran, or Cleveland Clinic in United States of America, and all concerned companies in this field. Thank you very much. So I just intended to make it more practical talk, not really a scientific talk, since some of the things has been covered by my colleague, Dr. Maha. Thank you very much.
Thank you very much, Dr. Muhammad. Very concise and informative presentation. We are open for the questions. Yes, Dr. Anna.
Thank you very much. Very interesting topic, and I think very hot topic in Oman, because sort of having children in Arab families is very important, and there are virtually thousands of families who are looking for answers. What I want to tell you is that we receive many samples for cytogenetics at National Genetic Center. Maybe 20% of our samples are from infertility clinic for karyotyping. And you are most welcome to get information. We can give you information, anonymous information about the last 5 years infertility referrals and what were the chromosomal rearrangements in them. And another thing that we started microarray diagnostics 3 months back, and we can do for you microdeletions of the chromosomes very easily. But what is my observation that from cytogenetics, there are many individuals with long Y and short Y chromosomes. And I think we have a fish for SRY gene as well. So you are most welcome to visit. In fact,
thank you, Dr. I'm very happy to hear that you can provide the service of the microdeletion, because this is very critical for the micro-testicular sperm extraction. As you know, if it is AFC, and the prognosis is more than if it is A or B. Thank you. There's one question.
Any more questions?
There's one question there.
Dr. Muhammad, you say that in your statistics, 5,536 individuals visited the health centers for fertility, and 4,000 visited the hospitals in 2012. But maybe some of them are the same patients that are overlapping. That means they are referred from the health centers to the hospitals.
I have tried to look at the Ministry of Health report during this year, which is the latest one. Unfortunately, it was not very detailed to know the exact details. So this is really crude numbers. As you said rightly, it can be repeated patients, absolutely.
Okay. And when you said combined in 30 clinics, that means it's for the male and female?
Male and female clinic, yes.
Thank you. Any more questions for Dr. Mohammed Al-Marhoun?
I just want to make a comment that the infertility is so heavy problem.
Anna, we don't hear you well.
Now? No? Hello? Can you
yes,
hear
now
me?
it's fine, yes.
So it's a difficult issue in community, and by the pressure from the demands, I know that many primary health care centers now doing sperm counts because the problem is so big and so hot. So there is a lot of clinics. In primary health care, you can get statistics from this, and then from secondary and tertiary care, there will be more complete picture.
In fact, I'm not very keen to have the infertility service at the primary health care center. Maybe a dedicated unit that can do basic testing, yes, but at the end, you would like to have a very advanced clinic that will take the patient through from the beginning to the end and know what is the exact problem and put the options to the couple, what we can do, including the assisted reproductive techniques.
Yes, Professor Sanfarouche? Oh, sorry. I think Sister Asma is before you. Asia.
I have two questions. You mentioned that there are 5 private centers in Oman. Where they are so do they do MISA, TISA, or PISA, that's sperm retrieval techniques?
Have you finished? Sorry. The private centers, they are basically providing the in vitro fertilization, intracytoplasmic sperm injection. This is the technology part of it, the embryology part. The embryology and andrology part. And they usually have a gynecologist who takes care of this. But I think the urology facility at the private centers are not to the level. Because even if they are doing sperm extraction, it will be on the simple basis and not really to the level of the microsurgery and the sophisticated. As you know, most of these infertile patients, like Klinefelter syndrome patients, you have really to search for the locus of sperm in that maybe atrophic testis. And to do that, you need a microscope, and you need to look at this dilated tubule and then extract it, then you will have the best chance of having sperms. And in fact, on Sunday, I'm having one case for micro-TC.
So that micro-TC you're doing, we need IVF, we need to go for ICSI
Of course.
after that
Yeah,
data?
so I'm providing the urology part here and collaborating with a private center to give them the sample. They will process the sperm and then prepare it for the in vitro fertilization or XC.
I think Professor Simfarouche had a question.
Do you have patients for vasectomy reversal cases in Oman, and how's the situation with vasectomy? I personally don't believe, and I don't do vasectomy for
It's a very good
preventing
question.
fertility. Do you have many patients for reversal, or you recommend them to do epididymal and ICSI?
The answer for reversal, we do not have a lot of patients. The reason is vasectomy is not done very frequent here. Very few patients come for vasectomy. And so obviously the reversal rate will be very, very low. Not like, for example, in the United States, like where I was in Cleveland Clinic. This is basically almost daily surgery they are doing the reversal.
That's very good, because there was a time that vasectomy was free in our country, but reversal was needed a lot of money. So now the trend is changed. But I personally never did vasectomy, and all the hospitals in my territory, they didn't do vasectomy. But it was very prevalent, and now we have many patients for reversal. So I recommend that don't look for vasectomy for population control if even necessary. Use other measure, because it causes a lot of social and medical problems for the patients.
In fact, for obstructive azoospermia patient, we may offer them, either they go directly for the assisted reproductive techniques, or they go for a trial of, reconstructive surgery, vasovasostomy or vasoepididymostomy.
We didn't have birth control in Oman here with WHO, but we had a program for birth spacing because for the health of the mother, because multiple pregnancies and with short interval caused health problems for the mother. So there was the program of birth spacing by the Ministry of Health. And I think it was through contraceptive to the mother and not through vasectomy. Maybe Dr. Marhoun can elaborate if you know about that.
I did not get your question, Dr. Nabil.
I mean, there was the birth spacing program from the Ministry of Health with the recommendations of the WHO, but for the birth spacing, vasectomy was not performed. I think it was more contraception of the wife. Maybe Dr. Anna knows that.
I know that vasectomy was also advocated,
Also, okay.
and in some areas, I know in Batna, so men gone for it.
Through the Ministry of Health?
Yes.
Okay. Thank you.
To my experience, vasectomy is very limited. And the few cases that I have come across, either they are expectorates or married to expectorate.
Yes, Dr.
Thank you very much. Just wanted to say that I'm, of course, from the College of Science, Department of Biology, but we have the central analytical facilities that there are, and a specialist that can do some sperms studies and so on. And he's internationally certified, so probably some of your samples you can send there for this type of analysis.
Thank you very much.
Sure.
Thank you very much, I think.
Are you talking about the center where all the analytical machines there?
Yes, exactly.
Yeah, in fact, I have visited the center, but maybe I'll be interested to know more about what sperm facilities.
There is a flow
test.
cytometer and a person specifically certified for the sperm analysis for the using the flow cytometry.
In fact, Professor Saif, the sperm analysis as a basic, we have it in the hospital.
You have it.
But I'll be more interested in the advanced tests for like the oxidative stress, like the DNA fragmentation of the sperms. This will be the advanced test that we'll be looking for.
I think you should ask that also because we
Absolutely,
have other...
yes. I'll revisit the center with
exactly.
great interest.
Sure. Maybe you can talk to people there that they can help
Absolutely.
you in this. Thank you very much.
Thank you. We are very honored by Her Highness Sayyida Muna, who has honored us with her presence now. And I think Dr. Marhoun was fortunate to be heard by Her Highness.
To listen what I have said.
Yeah. So thank you very much,
Thank
Dr.
you for
Marhoun.
coming.
And I think your presentation has was very active and has incited a lot of discussion. Thank you very much. And now,
Thank you.
Dr. Anna, maybe you can present Dr. Anna. You're going to co-chair now.
Thank you very much for inviting me, and thank you very much for Your Highness, Dr. Muna, for letting me to talk to you. So I will need a help here. So I will talk about the genetic services under Ministry of Health. Of course, Sultan Qabus University making a rapid progress in research, but we remain a healthcare provider for Ministry of Health. So genetic services in Oman commenced in the 90s when pediatricians attempted to improve the care of children admitted in the wards. And we started registration of families at the same time. Here you can see that there was a drastic fall in perinatal and under 5 mortality, which came with improvement of medical care in the past years. Before 80s, the perinatal mortality was 200, over 200, and you can see that this is old, 2005, but now it's around 7. And of course, this epidemiological change brought up also changes in what we see in the community. In past 20 years, the drivers were improvement of clinical genetic services, escalating needs for genetic tests, greater diagnostic care possibilities by the development of genetic science, improved understanding of genetic basis of multifactorial diseases, and support. We had also support from international bodies like WHO, World Alliance, March of Dimes. So the first service was for hemoglobinopathies, and we had a community outstretched program, but it was not well funded. It was more like charitable, but under this we established from donations a molecular lab for diagnosis of sickle cell and thalassemia to support premarital clinics accuracy, because now the premarital clinics exist in all regions and in many primary healthcare centers. So this was published work within the red circle. About 70% of sickle cell anemia patients reside, and within the blue is beta thalassemia high areas, and it reflects this map the migration patterns in the past centuries. So the genetic premarital screening service is available now in the regions, but it needs a lot of improvements, and lab capacity for that, for HPLC is not need to be improved, of course. So we gathered the data, and we had before only hospital-based data, and this reflects the genetic diseases in the population which were gathered from hospitals. And unfortunately, there was no population data. So this also the diseases, they confined to certain population groups and certain tribes. So you can put them on the map. And with the this population genetic exercise, you can save a lot of resources, because for screening, you don't need to screen all population, but you have to screen only the areas with high prevalence of these disorders. So we also were looking at the prevalence of the birth defects and Down syndrome, and a lot of papers were published about Hirschsprung disease and congenital heart disease and posterior lateral valves, and even those diseases which proven to be multifactorial, we have a positive and negative tribal aggregation in those, which opens a lot of possibilities for research in many areas in Oman. So the late study of the community prevalence of birth defect was funded by Research Council. We ran it for 2 years, and one family was questions per 600 Omani inhabitants. It was a very detailed study. And this is proven that 10% of Omani families have children surviving with birth defects and genetic conditions. And this is expected because there is an observation that there are more diseases in the community, but there was no reliable figures to support it. But now we have those figures, and this is published. You can look at the diseases which we find in the community. So this is a breakup of different conditions. So genetic blood disorders, they were only 11%. The deafness and blindness and the neurodegenerative diseases, but a big bulk, more than half, were conditions associated with intellectual disability, which need studies, because this is a bulk of the different conditions from birth, the brain malformations, microcephaly, neurodegenerative diseases, metabolic disorders, and many others, which are not up till now in Oman possible always to delineate, and it needs research, and major efforts must be from university and Ministry of Health to try and sort it out, because when you have a genetic test, then you open the doors for prevention in the family and the community. So from here we from this study, we conclude that the genetic conditions are common and remains a major contribution to mortality and morbidity and handicap. Intellectual disability is the commonest condition reported, but it requires additional study, and precise genetic diagnosis was unavailable in 3/4 of the reported condition, and over half of those had multiple affected. So the consanguinity data was also repeated in the study of 2011, and it is concluded that there is no significant change in consanguinity in the last 20 years from the basic study of 2000, of year 2000. So our priorities from this, we need to increase the public knowledge about genetic health and genetic disease avoidance. We need to modify genetic teaching materials for the medical professionals and for the community. We need to increase diagnostic capacity, clinical, biochemical, enzymatic, immunological, electron microscopy, and molecular genetics. We need to research the conditions associated with intellectual disability as a priority. We need to increase in public trust and improve dialogue between the public and scientists as important for acceptance preventive programs. So our direction in the National Genetic Center, we have cytogenetics, molecular cytogenetics, FISH facility, microarray diagnostics, and we have Sanger sequencing. I believe, working here for many years, that the successful development of genetic service in Oman will depend on 3 factors, and sustainable technological capacity in genetic testing is one, population literacy in acceptance of genetic testing, and also medical professionals' understanding on the benefits and technologies for patient care. So now our urgent obligations is a staff development. This is crucial. We have to complete international accreditation procedures in National Genetic Center. We have to master novel diagnostic technology. So we have some obligations for a 5-year plan for breast colon cancer, establishment, cystic fibrosis, osteogenesis imperfecta, and spinal muscular atrophy. And we need an urgent assistance to families with handicapping genetic disorders. So for our future vision, we want a genetic center in Oman and to become a center of excellence. And we need to translate new advances in the genetic technologies into medical practice and provision preventive measures. And our hope is to have now new genetic sequencer facilities, next generation sequencing, which will open a door to better services. Thank you very much.
Thank you very much, Dr. Anna, for this topic, which is a very important and hot topic in our country. Any question? Yes, that's right. I think there's a question.
You mentioned cystic fibrosis. So how common is it in Oman, that cystic fibrosis disease in here?
Yes, well, cystic fibrosis is common here. I think it's 1 in 20 or 30,000 deliveries, one case, and what is special, because we have a lot of unusual mutations which are common in other Middle Eastern and African states, which present not with pulmonary symptoms, but with gastrointestinal symptoms. And of course, in the panel of investigations for infertility, the test for cystic fibrosis must be included, because there are many carriers.
But you're not doing this?
Well, we are establishing tests. We are now gathering information about mutations, and we have a lady who is starting the testing. She's beginning, she's gathering, but a delay in consumables, delaying our progress a bit. So it will be, you are most welcome. It's Maha, Muna. She was working before in SKU on cystic fibrosis project, and now she is developing tests at the National Genetic Center. You are most welcome to come and visit her. She will update you what she's doing.
Dr. Anna, did you say cystic fibrosis 1 in 20?
Yes, 1 in 20,000 deliveries, yes. Maybe 1 in 10,000 deliveries, because we see maybe 6-7 cases new per year in 70,000 births.
That means this will increase our burden of infertility.
Yes,
Because
definitely, because they are infertile.
These patients,
yes.
They usually have absent vas deferens,
Right.
and then they have infertility issues. So
Right.
again, this supports that the infertility issue is a major problem in Oman.
Yes.
Please.
How often have you come across to polycystic disease of the kidney, and what's your recommendation for its prevention?
Yes, well, there is a big problem with the dominant polycystic kidneys, and there is also a lot of different kinds of polycystic diseases and renal dysplasias. We have in National Genetic Center one scientist called Intesar, and she is, together with the nephrologist at the Royal Hospital, she is putting applications for development of nephrogenetic tests here, because there are more than 600 individuals on renal dialysis due to those diseases. And it's a big, big number, and it opens the way for prevention. So we are trying to serve the population, as far as we can. So we are working on that projects. And if you have any ideas or want to put hands together, we will be very happy.
Thank you.
Dr. Anna, you said that intellectual disabilities is very common.
Yes.
And that 50% of the siblings are affected.
No, yeah, in 30% of these families, there are more than one affected, yeah.
More than one sibling,
Yes.
more than one child
Yes.
is
Yes.
affected. Now, how can we distinguish between the genetic causes versus the intrauterine causes, if there is asphyxia or
Right.
intrauterine growth delay?
Right. Okay, you need a lot of clinical skills to be able to delineate the cause and to crystallize the cause. And for this, there are a battery of investigations now. When this family is investigated, you have to exclude chromosomal anomalies with cytogenetics. You have to exclude metabolic disorders. You have to exclude microdeletions, and we have now tests to do this. We have microarray, we have metabolic tests which are mostly sent abroad or to SQ. We have a chromosomal test, we have to microarray. And we have to also crystallize the clinical picture, and we have many tests to do, including neurological tests and brain imaging. So if you see some pattern together with external features, with how the child develops, his developmental behavior, phenotype, and all the investigations. So this is
and these features would distinguish between the genetic versus the
yes,
intrauterine features?
Sure. But in Oman, there are many unusual conditions. I mean, me, myself, I described maybe 10 new conditions, because when we communicated to our collaborators abroad, they say, well, we never seen it. And I described so many new conditions and we mapped so many conditions from Oman. I mean, I can give you publication list. I have more than 65, 70 publications. And so there are many entities which are not yet to be described, but on the way of it, absence of access to the investigations like electron microscopy, like lysosomal enzymes, and so it's difficult to work it out. And we used to do it with collaborators. Now we want to do it with university. But you have to crystallize that phenotype and publish it, and then or now simply go to the new generation sequencer and see where it is and see. Because, for example, we described a family which was presented as a cerebral palsy, and none of them had asphyxia. There was 2 SIB-ships of 8 children affected. All of them typical asphyxial picture of palsy, but they are not, none of them have neonatal asphyxia. Then we mapped it to the condition called hereditary spastic paraplegia. It was unusual mutation, new mutations. And so we now know what's the cause. So it's a big job, but we are doing it.
Dr. Anna, just a comment. In fact, everybody knows that hemoglobinopathies are very common in Oman. And in fact, there are some peculiar genes in hemoglobinopathies described for Oman. I would be very interested to know if there is any relation between hemoglobinopathies and male infertility.
Well,
this is just a speculative question,
yes,
maybe to open future research.
It is very correct, because sickle cell patients are sterile, but it's developing, and you really need to get their molecular study if they have any sickle cell gene, or also should be included. And 10% of Omanis carry sickle cell gene. So this must be included in the panel. And what happens is microcirculation is always deteriorate because of the sickling, and microinfarctions are very common. So you need to test this for infertility pattern, sure.
If
I
I
can just comment
make
on
a
that
comment
last.
bit outside in fact, it's said that the autosomal recessive genes is, from evolutionary point of view, now for those who believe or not, that's under question, from evolution point of view, the recessive genes was a response so that the defective gene can be expanded in the population, because if it is homozygous, if it was dominant, then these individuals would be extinguished and be diseased and would die. So that's why the number of autosomal recessive diseases is much more than the autosomal dominant diseases. So I would expect not in this specific question, I would expect in general, not expect, in general, autosomal recessive diseases, they are fertile. And this is a way of the nature that has developed so that this defective gene can be developed without the individual die early.
Well, Doc, you see all the recessive diseases like sickle cell and thalassemia and even G6PD, they offered better survival in malarial areas on the account that the homozygous, affected, were dying before. And it was natural selection.
That's right.
Right,
Natural
but
selection,
now
yes.
they are not dying, they are surviving. And those will be infertile.
In Oman, they're surviving, but in Africa, they're still dying.
Right. But in Africa,
Still-
there is no
still
genetic
malaria
disease.
is a big
Correct.
killer in Africa.
Correct. But in Africa, there is no genetic diseases, like it was not seen at all in Oman before His Majesty Sultan Qabus came, because they used to die in the first year, on the first days.
Can I make a comment here? Because
Dr. Maha, yes.
I just want to share our experience in SQUH with regards to inherited hemoglobinopathy in male and female infertility, because we are treating them, and yes, they are surviving. So in fact, we've collaborated with the Department of Hematology. Basically, the etiology for infertility in males is hypogonadotropic hypogonadism, and it's the same for females, most likely because of iron overload. So we've been treating those patients. The hematology department actually is treating the men who were